My name is Ram. I am a second year medical student at Maharajganj Medical Campus. I would like to welcome you all in this webinar, and the topic for this session is case discussion on acute pancreatitis. So on the behalf of the Grey Medicos, it is the matter of honor and privilege to welcome Professor Dr. Palesawan Lakhey ma'am as our mentor for this webinar. She is the head of Department of GI Surgery at Tribhuvan University Teaching Hospital. I would also like to welcome Dr. Kanchana Bali as the presenter for today's session. She is intern doctor at TUTH. So we extend our heartiest welcome to all the participants, and we are thankful to our delegates, to our ma'am and me. So before beginning this session, I would like to read out some of the rules that a participant have to follow. So each participant is requested to be present with their genuine name and the institution they belong to. So please, if you are not present with your genuine name, please edit your name and write the institution you belong to. And every participant will be muted, and spamming is strictly forbidden. If found, then he or she will be discarded from this session. And we would be having a Q&A session later in this session. So anyone who do have queries, please drop your queries in the chat box to one of our co-hosts. They will convey your queries to our mentor ma'am. Now, without further delay, I would like to hand over the platform to our program coordinator, Sujan Sarmadai, for his valuable welcome note. Sujan Dai, please.
Okay, thank you, Ramarial Bhai. Namaste, everyone. Respected ma'am, senior brother, sister, and all the participants. Myself is Sujan Sharma, currently MBBS third year student in Maharajganj Medical Campus. Welcome you all in this session on behalf of the Grey Medicos team. Yes, the term grey, it represents a color, which is the transition between two colors, but not it distinguishes between exactly two different colors. Just like that, we are the group of students who passes through the two phases of medical life, from knowing nothing to the knowing something. And we hereby bringing you a weekly session of different case discussion through this platform with the involvement of the different faculties and senior doctors from the medical colleges of Nepal, thus to make the enthusiastic and effective session. This group is totally based on study purpose, such to fill up the knowledge with the common clinical cases in our hospital. Believing that we all medicals will be regularly updated through this session when we are devoid of the hospital hour due to the ongoing pandemic situation in Nepal. I hope we all grab a lot of knowledge from this session. And once again, welcoming you all in this session. I'd like to conclude my speech and again hand over to Mr. Ramarial. Thank you.
Okay, thank you, Susan Dai, for your valuable and sweet speech regarding the motto of the session and the introduction of this group, the Grey Medicos. Now, with no delay, I would like to hand over the floor to our presenter, Dr. Kanchana Validi. So we can start now. You can take over.
Thank you so much, Bhai. First of all, I would like to thank the Grey Medicos team for giving me an opportunity to dwell back into one of the topics that I have always been very interested in. And secondly, I would like to say that it is a matter of great honor for me to have my picture beside Palesawan ma'am's picture, someone who has inspired me throughout the years and someone whom I admire a lot. So thank you for this opportunity. And I believe that we will all have a lot of learning experience today from someone as fluent and as good in her work as ma'am, and we'll have a lot of things to learn. So welcome, ma'am, and thank you, everyone. So without any further delay, I'll be getting into the case presentation. So this case was one of the cases that I got an opportunity to witness in my junior internship in one of my night shifts. And that was when usually the transition between theory and actually going in the emergency and tackling cases was a difficult one. So that was a great period for us as well. So I think this will be really interesting, and I hope it's a good session and you guys get to learn a little bit from me as well. Imagine that while you're working in the emergency department, an elderly patient presents with severe epigastric pain. After appropriate initial triaging, which is done right outside the emergency for medical students who have not been exposed there yet, she presents to the yellow zone. So basically, the emergency room is divided into 3 zones, the red, the yellow, and the green zones. And on the basis of severity, patients requiring some immediate management go to the red zone. If they can be seen between immediately and about 10 to 15 minutes, they go to the yellow zone. And if we can wait and watch, they go to the green zone. So after appropriate initial triaging, she presents to the yellow zone where you are the doctor on duty. So how will you proceed? So initially, the first thing that we learn as medical students is to take history. So I'm going to be now describing the history of this patient, and progressively we're going to reach the diagnosis. So my patient, Mrs. Bhujel, 70 years old female from Dhading, was a married Hindu housewife. She came with the chief complaint of epigastric pain for 2 days. Her abdominal pain was sudden in onset, and it began in the epigastric region and later became generalized. It was continuous, dull aching in character, and it radiated to the back. The epigastric pain was not related with food intake, and it was moderate to severe in intensity. There was no variation with timing, and there were no aggravating or relieving factors as such. It was associated with 4 episodes of non-bilious, non-projectile vomiting containing food particles, and there was no blood in the vomitus. As I dwelled further and talked to the patient more, she told me that there was no history of jaundice or yellowish discoloration of the sclera, and there was no fever. She did not have any history of constipation or abdominal distension. There was no history of dyspepsia, no history of black-colored stool or blood in stool. Patient did not complain of weight loss, and there was no loss of appetite. Her bladder habits were normal, and there was no chest pain or cough. With this history of presenting illness, I moved forward to ask the patient if she had any other pre-existing conditions. So the patient was a known case of hypertension under medication. She had been hypertensive for about 3 years, and she was currently taking tablet amlodipine 5 mg. And she had no history of previous similar episodes, which meant that she did not have prior incidences of similar epigastric pain in the past. There was no history of diabetes mellitus, and there was no history of any lipid disorders or patient taking medications for any lipid abnormalities. Similarly, she did not have any history of previous surgery. Being an elderly patient, although the patient did not know of her family history itself, she remembers that her parents did not have history of diabetes or hypertension as such, but this history was a little difficult to elicit. Similarly, she did not have history of consumption of alcohol, but she has smoked 4.5 pack years of cigarette, and she had left smoking 6 years back. Similarly, her sleep and appetite was normal, and she was menopausal. Socioeconomic history: they had a separate kitchen in their house. She drank filtered water and used LPG for cooking. There was no history of any drug allergies. With this, I come to the end of my history. So just wanted to reiterate for my fellow juniors who are in the first and second year, a history has these many components, including the introduction, chief complaint, history of presenting illness, past medical history. In case of surgery, we also require past surgical history, family history, personal history, socioeconomic history, and drug or allergy history. With the following history, I proceeded to examine.
Kanchana,
yes, ma'am.
Let me interrupt you after finishing your history. Okay,
Yes,
so what I believe is, and some examiners would want to know certain your working diagnosis and differential diagnosis immediately after history.
Yes, ma'am.
because unless and until you have some diagnosis in your mind, you will not be able to elicit certain signs in your examination, right?
Yes,
So
ma'am.
with your such a beautiful history, what do you think would be the few differential diagnoses in this patient?
Ma'am, my differential diagnosis would be as follows. So, because the patient presents with epigastric pain, firstly, because of the nature of the pain, that it is because it is short-lived and because it is continuous and because it radiates to the back, my provisional diagnosis would be acute pancreatitis. However, I would also like to look for perforated peptic ulcer in this patient. Uh,
Mhm.
and and I would also like to look for signs of intestinal obstruction. That would also be my differential diagnosis.
Okay. So
And
basically, this elderly lady has epigastric pain, right? Which radiated to
yes,
the
ma'am.
back. But
Yes, ma'am.
but you did. I hope you must have asked, but I think the pain did not relieve on stooping forward, which is a very characteristic pancreatic type of pain that we describe, right?
Yes, ma'am. Yes,
So
ma'am.
obviously, the first diagnosis, as you thought, would be acute pancreatitis. Yes, as you said, it can be perforated peptic ulcer disease. Okay, so it can be just peptic ulcer disease as well, without perforation as well. It can be biliary colic, right? So whenever you talk about intestinal
Yes, ma'am.
obstruction, you need to be more specific whether you are talking about small bowel obstruction or large bowel obstruction. I think I presume you wanted to say small bowel
Small bowel
obstruction.
obstruction.
Okay. So what
Yes, ma'am.
else?
Ma'am, because this is epigastric pain, I would also like to look for any causes present in the chest area. So I would also like to rule out myocardial infarction, which may sometimes present with an epigastric pain, and
Very good.
also at times basal pneumonia may also present with epigastric pain. So I would also like to look for chest-related causes of epigastric pain.
Right, excellent. And I also would like to add mesenteric ischemia as one of the differential diagnoses, because this is an elderly patient who is hypertensive. Okay, so that should also be included in
Yes,
the
ma'am.
differential diagnosis. So we have now acute pancreatitis, perforated peptic ulcer disease, and then maybe acute small bowel obstruction. Okay, and then it can be it can be biliary colic, it can be mesenteric ischemia, then you can put myocardial infarction and basal pneumonia. Okay, right?
Yes, ma'am.
Okay, let's go to the examination.
Yes, ma'am. So, with this history, I proceeded to examine the patient. So, on general examination, the patient was conscious, cooperative, and well oriented to time, place, and person. Patient was of average build and was in sitting position with 20 gauge intravenous cannula on her left hand. On further evaluation of the patient, her vital signs were as follows. Her pulse was 75 beats per minute, normal in volume, rhythm, and character. Her blood pressure was 140 by 90 millimeters of mercury, as measured in her left hand in sitting position. Her respiratory rate was 22 breaths per minute. Temperature was afebrile, and oxygen saturation was 93% with 2 liters of oxygen. Initially, while triaging, the patient's saturation had been measured and she had been kept on a bed with a nasal cannula in place. I believe I have a slide here missing of the general examination of the patient. So on head-to-toe examination, the patient did not have pallor. There was no icterus, there was no lymphadenopathies, no evidences of cyanosis and clubbing. The patient did not have edema and she did not exhibit any signs of dehydration. Moving forward to the per-abdominal examination. On inspection, her abdomen was distended. All quadrants were moving equally with respiration. Umbilicus was central and inverted. There were no scar marks, dilated veins, prominent venous pulsations, or visible peristalsis. There was no bruising around the umbilicus or on the back. Hernial orifices were intact and there was no visible mass in the abdomen. On palpation, on superficial palpation, there was no local rise in temperature, guarding and rigidity were absent, tenderness was present in the epigastric region, and there was no organomegaly. On percussion, tympanic node could be felt all over the abdomen and there was no shifting dullness. On auscultation, bowel sounds were present. And on per-rectal examination, anal tone was normal, there was no palpable mass, finger was stained with feces, and there was no blood on the finger. This brings me to the end of the examination. I also want to add here that the patient's cardiovascular examination showed first and second heart sounds with no murmurs and no added sounds. Her chest examination showed bilateral normal vesicular breath sounds. However, there was decreased air entry on the left side. There were no other added sounds. This brings me to the end of the examination.
So, Kanchana, so what are the things did you specifically see to come to your provisional diagnosis of acute pancreatitis?
Ma'am, on examination, I looked for the general condition of the patient. If the patient had a lot of pain, or if the patient was conscious and cooperative at the same time or not, which gives us an idea about the severity of any disease that could have been. So it would have helped us triage whether the patient would need further immediate management or the patient was stable for a while till we finished the examination. And along with that, ma'am, the vital signs were also taken into account in order to consider not only the severity, but also symptoms related, but also signs related to effects of acute pancreatitis, such as if the patient had features of hypovolemia, or if the patient has changes in abnormalities in respiratory rate, which could be because of the complications related. This also helped, the vital signs also helped in differentiating other causes of epigastric pain that the patient might have had. For example, if the patient was in shock, it could have also been because of other cardiovascular conditions. And if the patient's pulse was irregular, it could have pointed further towards other causes of epigastric pain. And the patient's temperature was afebrile, which also supports pancreatitis in a way that fever is not usually, would point more towards other causes such as probably acute cholecystitis, which could have caused the epigastric pain rather than acute pancreatitis per se. And further evidence, looking at the saturation of the patient, we could also believe that it could also help us assess the severity of the disease, as well as if there were any local complications that could have happened within the 2 days that could have led to decreased saturation. Along with that, on abdominal
so in general
Yes, ma'am.
physical examination, the vital signs are very important, right? Because
Yes, ma'am.
it will tell us some components of SIRS, that is Systemic Inflammatory Response Syndrome.
Yes,
So I
ma'am.
would like all of you to keep this in mind, that SIRS, presence of SIRS is a very good sign indicating that the patient has what is the severity of disease in that patient, whether in preoperative stage, like in this case in emergency room, or in the ward, or in the post-operative ward. Okay, so please just get yourself acquainted with the components of SIRS, that is Systemic Inflammatory Response Syndrome. Right? So that is important at this point of the time. Okay. Yes.
Moving forward, ma'am, on per abdominal examination. Before this, I also did the head-to-toe examination, which could have further led to differentiating whether the pain was due to acute pancreatitis or not. So if the patient had pallor, then we could have, it might have pointed us towards blood loss in a certain way, or long-lasting blood loss, or peptic ulcer disease as well. So that could have been one of the differential diagnoses that we have been able to rule out by doing the head-to-toe examination. Similarly, the presence of icterus would have, would have firstly helped us see if the patient had a reason for pancreatitis. For example, if the patient had pre-existing gallstones that could have it would have supported pancreatitis, as gallstones are also one of the causes of acute pancreatitis. So presence of icterus or absence, although absence of icterus does not rule acute pancreatitis, presence of icterus would have been a supportive evidence to say that this could have been because of a gallstone. And similarly, cyanosis and clubbing were not present, and these are not typically findings that we anticipate in patients with acute pancreatitis. And there was no lymphadenopathy, which rules out malignancy leading to blood loss or epigastric pain in an elderly patient. And there was no evidence of edema or dehydration, which also, although it's a general head-to-toe examination, so even if not directly it does not directly help us find out evidences of acute pancreatitis, it helps us rule out other causes as well. So on per abdominal examination, ma'am, specifically in a patient with pancreatitis, we would expect to see on inspection there are two signs which are typical or classical for acute pancreatitis, which are known as Cullen's sign and Gray Turner's sign, which is characteristic of bleeding through the fascial planes, which causes bruising around the umbilicus and in the retroperitoneal area. So if there's the presence of these signs, then these can point towards the diagnosis of acute pancreatitis, more specifically more severe disease than just mild pancreatitis. So these are the signs that we would typically expect. But other
Kanchana, the Cullen sign would be the ecchymosis around the umbilicus, and the Gray Turner sign would be Gray Turner sign would be ecchymosis in the flanks. And although the textbooks have described this indicating severity of acute pancreatitis, but we hardly see patients in our clinical practice with Cullen sign and Gray Turner sign. Okay, although, but you need to know these things. It may be asked in the exam. In clinical practice, we hardly see these findings. Okay. Yes. Now, in your abdominal examination, your differential one was peptic ulcer perforation that you need to rule out, right? And the other is mesenteric ischemia, where also the patient will have signs of peritonism. Okay, so you need to explain what are the signs of peritonism and peritonitis, right? And then, yes, okay.
Yes, ma'am. So on palpation, on superficial palpation, there's no local rise in temperature and there was no guarding and rigidity. So if a patient presents with perforated peptic ulcer disease or even signs of mesenteric ischemia, which points towards peritonitis, then there is change in history, there's change in the nature of pain. So if the patient typically describes it as pain that was previously in the epigastric region, then after some time the patient tells us that the pain became continuous. So that was also present in our patient. So I had to proceed with caution and see if the patient had symptoms of continuous generalized pain in the abdomen. And on palpation as well, the patient would generally complain of, on superficial palpation, the abdomen would be board-like and rigid. So firstly, because of pain, the patient would voluntarily contract the muscles, and because there is associated peritonitis, the abdomen would feel very firm and rigid on palpation, and it wouldn't be as soft as normally abdomens are on palpation. And similarly, here the pain is localized in the tenderness is localized only in the epigastric region. So if a person presented with peritonitis, then it would be such that the patient's abdomen would be tender throughout. So there would be tenderness present throughout the abdomen. So if those signs were present, then it could have given a clue as to whether the patient had signs of peritonitis due to either perforated peptic ulcer or mesenteric ischemia, ma'am.
And at this point, it is very important, although Dr. Kanchana has already explained the definitions of guarding and rigidity. Guarding means voluntary contraction of the muscle, because of pain while you are examining. And then rigidity means the peritonitis, and the pain is so severe that patient is scared that when you touch, he or she will have pain. So the muscle is already contracted. So involuntary contraction of muscle response to pain is rigidity. Okay, voluntary contraction in response to pain while examining is guarding. So your long case, you might be asked what is the difference between guarding and rigidity. Okay.
Ma'am, further, there was no organomegaly present in the patient. So,
So,
if it had
Kanchana,
been,
Kanchana, the
yes,
other
ma'am.
point is, since we had perforated peptic ulcer as differential diagnosis, I think you also need to talk about the whether the liver dullness was obliterated or not. Okay, so any patient with acute abdomen, that you need to see whether the liver dullness is obliterated or not. I hope everybody knows how to check that. You first identify the sternal notch, right? Then go down, you'll feel the sternal angle, and go to the right side. That would be the second intercostal space, and then you start focusing the intercostals come down in the mid-axillary line. As you go down in the fifth intercostal space, you'll start appreciating dullness because of the upper border of the liver. If that dullness is obliterated, then it suggests that there might be gas under the diaphragm. Okay, suggesting peptic ulcer perforation. Liver dullness may be obliterated in a condition known as where there is interposition of the transverse colon. The condition is known as Chilaiditi's sign.
Syndrome.
Right. Okay.
Moving forward, ma'am, on percussion, I believe that I missed doing obliteration of liver dullness in this patient.
No problem. Okay.
But on percussion of the abdomen of the patient, a tympanic note could be heard throughout the abdomen, and there was no evidence of shifting dullness. And on auscultation, bowel sounds were present. So presence of bowel sounds also helps us rule out one of the previous differential diagnoses that we had of subacute intestinal obstruction.
Right.
So on per rectal examination, which is also an indispensable part of abdomen examination, anal tone was normal and there was no palpable mass, and the finger was stained with feces and no blood was present on the fingers.
So just to make a point, although sometimes we in patient who have peritonitis, sometimes we may not do rectal exam. But what I would like to stress is that rectal exam consists of three components, right? Besides taking consent, maintaining privacy, having an attendant, okay, and the patient, you need to put the patient in Sims position. After that, there are three components. One is inspection, just inspection, where you see whether there are any anal tag or not, whether there is any external hemorrhoid, any external opening of a fistula, any soiling of the perianal area with stool or feces. All things you need to see in inspection. Then you do digital rectal examination with a gloved and lubricated finger. And while doing digital rectal examination, first you see feel the resting anal tone, which is the function of the internal sphincters. Then you need to assess the squeeze pressure. That is the function of the external sphincters. Then you insert your finger inside, feel all over the rectal wall, and then you need to ask the patient to strain as well, because sometimes you may not feel a mass which is a little bit higher up, especially when you have a small finger. So when the patient strains, the mass may just descend and you may able to feel. Okay, and then you withdraw the finger, and the most nasty thing that you need to do is you need to see whether the finger is stained with blood or not, as you have very rightly mentioned. And if the finger stains with blood, or if you feel something, or if the patient complains of bleeding rectal, and the third component of rectal exam is proctoscopy. Okay, right? So although
Yes,
it is
ma'am.
not, this may not be important in this patient, but I just wanted to make a point that what are the components of proctoscopy. rectal exam. Okay.
Yes, ma'am. Thank
Okay.
you, ma'am. So with this, I would like to summarize my history. So summarizing it, my patient, a 70-year-old non-alcoholic hypertensive female, presented with the complaint of epigastric pain for 2 days, unrelated to food intake, associated with multiple episodes of vomiting. There was no blood in vomitus, no jaundice or black-colored stool, no history of previous surgery or similar episodes in the past.
So this is just the summary of your history. So when you
Yes,
make
ma'am.
a summary, as you have very rightly mentioned about important negative history as well, you also need to make a summary of the clinical exam.
Yes,
Okay.
ma'am. So I will verbally say the summary
Yeah.
of the examination.
Right.
So,
Right.
the patient was conscious. Vital signs were within normal limits, except saturation was 93% with 2 liters of oxygen, and uh, respiratory rate was 22 breaths per minute. Her head-to-toe examination was normal, and abdominal examination showed abdominal distension and no bruising around the abdomen, around the umbilicus or the back. And on palpation, there was no guarding or rigidity, and tenderness was present over the epigastric region. On percussion, tympanic note was heard, and bowel sounds were present.
Okay. So I would like to request all the medical students to learn how to make a summary. Okay, it's just like writing a comprehension in your English literature or something like that. So all of you need to learn, because this is the way where you will be communicating with your consultant or with your residents as you go on in your training. Okay, it's summary is very important, right? So after summary, so you've already shown us the slide. The provisional diagnosis is
Acute pancreatitis, ma'am.
okay. Can you tell us the pertinent points why you think it is acute pancreatitis?
Ma'am, I think this patient has acute pancreatitis because the patient presented with her first episode of epigastric pain, and it was associated with vomiting, and the pain radiated to the back. Along with that, uh, uh, the patient did not have any other symptoms. Ma'am, should I just tell the points in favor for pancreatitis or also the negative
No, no.
history that?
So that is it. So when you talk about provisional diagnosis, when you think it is acute pancreatitis, you just speak for only. You just try to prove that this is acute pancreatitis with whatever evidence you have, not to the extent that you argue, but you discuss in a logical way. Okay, you just talk in terms of for the provisional if you acute pancreatitis is provisional diagnosis. Okay. And
Yes, ma'am.
and if okay, so your differential diagnosis was one of the differential diagnosis was perforated peptic ulcer disease, right? So you can say that my first differential is perforated peptic ulcer disease, because the pain was sudden on onset in the epigastrium, right? And then you can say it is less likely because there are no signs of peritonitis, okay, in examination, right? And similarly you can defend like that of mesenteric ischemia. Similarly, you can differential diagnosis, you can say acute small bowel obstruction. It is less likely to be acute small bowel obstruction because the patient does not complain of abdominal distension, there's no history of obstipation, and on examination the abdomen is only slightly distended, the bowel sounds are present, so you defend like that. And then the other differential was biliary colic. Okay, and the biliary colic is less likely because in biliary colic the pain persists not more than 6 hours. It relieves after 6 hours, and then within 6 hours. And the other point against biliary colic is, although you did not specifically ask, I hope you asked, that you did not mention that the patient pain did not aggravate with fatty food, or in other words, the patient did not have had fatty meal intolerance. Okay, so what I wanted to make a point here is, when you talk about provisional diagnosis, you mention points for that diagnosis, and when you talk about differential diagnosis, you talk about against. It's not this because this is not there. Okay, right.
Yes, ma'am.
So what are the other differential diagnoses in this patient?
Ma'am, the other differential diagnoses in this patient include perforated peptic ulcer disease and mesenteric ischemia.
No, besides that.
Other differential diagnosis also includes pneumonia, ma'am, basal pneumonia, and also myocardial infarction, but
yes,
I would still like
this
to
patient may
put
have
myocardial infarction and pneumonia as a differential diagnosis, because
management varies, right? And it's a real case scenario. One of a very influential person had severe epigastric pain, and he went to one of the very reputed private hospital in Nepal. And then since that was considered as a cardiac hospital, your initial diagnosis that was made was angina, okay, angina, or this thing, myocardial infarction, and very less amount of fluid was given, and then the patient died because of inadequate resuscitation, and it turned out to be acute pancreatitis. Okay, so I would like all of you to keep this in mind, that myocardial infarction is a very important differential diagnosis in case of acute pancreatitis. Although these days all the investigations are done in one go, so it will be ruled out immediately in the emergency room, but still you need to have in your mind, because says that what you cannot see what is not, you won't see if it is not there in your, something like that. If your mind doesn't know, your eyes will not see, right? Okay, so
yes,
now,
ma'am.
how will you investigate, like how will you work up this patient?
For the workup of this patient, I would like to send certain investigations. So the investigations would include baseline complete blood count, which would include total count, which is total white blood cell count, and HB, which stands for hemoglobin, and platelet levels. I would also like to do RFTs, which are renal function tests, and these include urea, creatinine, and electrolytes such as sodium and potassium. Along with this, I would also like to do liver function tests, such as total bilirubin, direct bilirubin, SGPT, and SGOT. I would like to send for a random blood sugar level, and also send for amylase and lipase levels in this patient. The things that I've missed in this investigation are, I would also like to send for an ECG to rule out myocardial infarction, ma'am.
Okay, ECG and other baseline investigation like chest X-ray is important. And the other thing is that
Yes.
you will, in the emergency room, you will get the transabdominal ultrasonography as well. Because according to the
Yes.
revised Atlanta classification, in order to make the diagnosis of acute pancreatitis, we take into consideration three things: clinical features, biochemical parameters, and radiological features. So clinical feature, as you have explained, this patient has typical epigastric pain which radiated to the back, but it did not relieve on stooping forward. But anyway, the patient has got epigastric pain radiating to the back. So clinically, it's clinical feature is there. And the second thing is amylase and or lipase 3 times that of the normal serum value, right? So
Yes.
it depends what is your institutional value. At our institute, I think it is 100 international 100 units per liter. So in this patient it is 400. It means that it is 3 times more than 3 times the normal. And I think the lipase value is also more than 3 times the normal, right? So
Yes, ma'am.
biochemically also this patient has, it suggests, so clinically and biochemically. So out of the three features, two features are there. So already the diagnosis of acute pancreatitis is already made. And then sometimes when amylase lipase may not be elevated, for example, in patients where the acute pancreatitis is because of is alcohol induced, or if the patient has presents to you after 2 days like this patient, right, the amylase level may have been elevated and has decreased gradually over the period of 48 hours. So amylase may not be elevated in these conditions. Okay, and lipase may also not be elevated. So in those conditions, imaging is important. Okay, imaging to, one is to see whether the pancreas is bulky or not, but you all know that in transabdominal ultrasound, because of the because of the overlying stomach, pancreas may not always be visualized. But it can rule out other things like presence of gallstone, okay, whether the patient has got other pathology like collection or not. All those things you can see in the transabdominal ultrasonography. So those three things are important to make the diagnosis of acute pancreatitis. And at the same time, what I would like to say is that we should not always rely on this amylase level, because it may be elevated in any acute abdomen. Amylase may be elevated even in perforated peptic ulcer disease, even in ectopic pregnancy, even in pericolic acute cholecystitis. But lipase is said to be specific. Okay, so at this point of the time, do you have the ultrasound of the abdomen report?
Yes, ma'am.
Okay, so
Uh,
here, what I would like to request all our students is that whenever I go for examination for MBBS, like I don't go often, but when I go, they say ultrasound, okay, and that sounds so non-medical. So I request all of you to say either ultrasound of the abdomen and pelvis, or the better would be trans-abdominal ultrasonography. Okay, because ultrasound can be done of anything. You can do esophageal ultrasound, you can do rectal ultrasound. Okay, so please use the term transabdominal ultrasonography. Right.
Yes, ma'am. So for investigations, as ma'am mentioned, the diagnostic criteria for acute pancreatitis, I would like to recall it and make sure my juniors remember it as well. So it includes one of the either two or of the three criteria, two or more. So the three criteria include, firstly, a patient who presents with clinical symptoms that are congruent with that of acute pancreatitis, that is epigastric pain that radiates to the back. Second is a patient should have biochemical evidence of acute pancreatitis. So it is amylase and lipase levels. Amylase and lipase levels are markers of pancreatic function. And if these levels rise more than 3 times, then it is also a sign of acute pancreatitis. And the third is there should be radiological evidence of acute pancreatitis. So there should be evidence that there are some changes in changes that have been visualized radiographically. So these are the diagnostic criteria. So coming back to the investigations, in the emergency, I think many of you may have been exposed to the emergency environment. Many of you may not have been. But usually when we send for investigations in the emergency, it is not because we haven't thought of anything else and we're just sending all the investigations. Every single investigation that you see in this slide will have some relevance. Even if we don't see it now, later in the later slides, we will come to know that everything is related, either in ruling out a diagnosis or in making a certain investigation come in favor of a diagnosis. So for example, I would only like to give an example here. For example, if we hadn't sent the hemoglobin levels, and if there had been blood loss or intra-abdominal blood loss, which we may not have seen. So hemoglobin levels would have provided a clue to some other diagnosis if a patient had, for example, a perforated or bleeding peptic ulcer, which would have led to decrease in hemoglobin levels. Because clinical signs, although they're relevant, they might take time to develop. So these lab findings in one way or another help us in including or excluding a diagnosis. So now in this patient, the patient had total leukocyte count of 8,800. This is normal. The normal leukocyte count is 4 to 11,000 per cubic millimeters. And in this, the patient had 72% of neutrophils and 25% of lymphocytes. Similarly, hemoglobin was 13 gram percentage, which is normal, and platelets are 1,22,000, which is a little bit less than normal, but we still regard it as acceptable. Similarly, the patient's renal function tests show that the patient's urea was 5 millimoles per liter and her creatinine levels were 144 milligrams per deciliter. So we're dealing with a patient who has a gastrointestinal problem. But why are we sending renal function tests? Because renal function tests are also a marker of other, if that condition could have led to some other damage to some other organs as well, which is called organ failure. So we need to look for a renal function test as a baseline, as well as to see if there is any damage to the kidneys that have happened because of the existing condition. So the patient's electrolytes were within normal limits. Similarly, as ma'am mentioned earlier, in cases where there is alcohol-induced pancreatitis, liver function tests provide us a clue to see what the cause of acute pancreatitis was. So this brings me to mentioning the cause of acute pancreatitis. The most common causes, there's a mnemonic that I used to remember the causes of acute pancreatitis when I was preparing. So it's called I get smashed. And there is a lot of things that can cause pancreatitis, but I stands for idiopathic, G stands for gallstones, and E stands for ethanol or alcohol. So these are the three most common causes of acute pancreatitis. And other causes includes trauma, which comes with T. Then there's a lot of different abnormalities, such as hypertriglyceridemia. So leading up to scorpion bites, which are very rare. But for now, let's just remember that idiopathic gallstones and ethanol can cause acute pancreatitis. So if there's derangement in liver function tests, then that would provide a clue as to what the cause of pancreatitis could have been. Similarly, the patient's random blood sugar level was 126 milligrams per deciliter, and we will see why this is important. Generally, random blood sugar levels are sent for in the ER as a protocol. In every patient whose vital signs are measured, we make sure that we send for the random blood glucose levels as well, because the patient may be diabetic to begin with, and we may not know about it, and there are going to be a lot of medications that we use, as well as people who are diabetic or have high blood glucose levels have other associated problems with it. So we would like to be safe, and we would just like to rule hyperglycemia out. And following that, we also have amylase and lipase levels, as we've discussed with ma'am earlier. So I would like to move forward from these blood investigations. And these are some...
Kanchana,
Yes, ma'am.
Excellent. She has explained in very nicely. Okay, excellent. What I also want to stress is that in acute pancreatitis, it's important to know the baseline hemoglobin level. Okay, because and even this random blood sugar, because all these are included in the scoring system to predict whether the patient has got severe acute pancreatitis or not. Okay, so after resuscitation, you will realize that the hemoglobin level will fall. Okay, and if the hemoglobin level falls more than 10%, then that indicates that hematocrit falls more than 10%. That indicates that this patient will go on to develop severe acute pancreatitis, right? And the other thing is that the level of creatinine is important to see whether the patient is dehydrated or not. And it is also included in modified Marshall scoring system, which is important to triage the patients of acute pancreatitis at the emergency, deciding which patient will require high dependency unit. Okay.
Yes. Thank you, ma'am. Moving forward, I've also listed some investigations which are done on need basis in the emergency. So personally, after working for 1 month in the emergency, you tend to, I think that's where you learn when to send certain investigations and when not to. And here, serum calcium levels are also important in severity assessment. So although they're not sent immediately when a patient presents with epigastric pain, you make sure that you send serum calcium levels at some point of time, because that also helps in severity assessment. Similarly, serum albumin, it comes under a liver function test as well when we send it, but I've mentioned this separately because this is also used as a marker of severity. Along with that, lactate dehydrogenase is used as a marker of severity. And serum triglycerides level have also been mentioned here because they also are one of the causes of acute pancreatitis. So if there's any patient in whom evidence of gallstones is not there, or the patient does not consume alcohol, or there's no evidence of trauma, then slowly we begin to look for other causes of acute pancreatitis. So we do these investigations. Similarly, now there's the role of ABG. So ABG is arterial blood gas analysis. So usually when we send investigations to from the emergency, we draw venous blood and we send the investigations. However, arterial blood gas analysis is also very important in acute pancreatitis patients because it is also used to classify pancreatitis into mild, moderate, or severe pancreatitis. And in the coming slides, I'll be coming to how these patients are classified, whether as mild case of acute pancreatitis or severe or moderate cases. So for now, arterial blood gas analysis, for usually we tend to be very one-tracked when we begin out. So when we go to the emergency, we don't think of any supposedly pulmonary test or blood gases to be done in a patient with a gastrointestinal problem, but because our human body is interlinked in various ways, there's an effect of all these different things on this one particular disease. So I hope you all keep that in mind, and I'll move forward and then we'll see where exactly it comes into use. So moving forward, so other investigations that I would send from the emergency include a chest x-ray, firstly to rule out basal pneumonia, which was one of my differential diagnoses in the beginning. And then other reason why I would like to send for a chest x-ray is because acute pancreatitis may present with some complications, and that also gives us an idea into how severe the patient's disease is. So typically left-sided pleural effusions have been said to be a complication of acute pancreatitis, and here in this chest x-ray, I've tried to put an x-ray of a person with left-sided pleural effusion, although not necessarily this patient had acute pancreatitis, but this is a picture that I took off the internet. So so if you can see, the yellow arrow points towards a point in this x-ray, which is towards the left side. And you can see that if you compare it to the right side, you can see a white shadow there. So this white shadow is called radio opacity, and this opacity signifies that there's some form of fluid in the x-ray, because in the on a chest x-ray, gas looks black and fluids look white in color, and the black color is known as radiolucent and the white color is known as radio opaque. So this radio opacity in the left lower hand corner on this chest x-ray signifies that the patient might have pleural effusion. So moving forward, ma'am. Then I would also like to send for an x-ray of the abdomen. So the x-ray of the abdomen would be to firstly rule out subacute intestinal obstruction. I also forgot to mention in the previous x-ray, I would also like to look for gas under the diaphragm on the chest x-ray, because one of my differential diagnoses was perforated peptic ulcer disease. And perforated peptic ulcer disease presents with the typical sign of what we call pneumoperitoneum, which is gas under the diaphragm. So if you can see on the right-hand side, you can see the lower border of the liver. So that's the lower border of the lungs, and which is the border of the diaphragm and the interface between the diaphragm and the lung. I'm trying to, okay, so this is the lower border of the lungs, as you can see on this x-ray, and this demarcate this,
or you can say that's the diaphragm. Outline of the diaphragm.
Yeah, that's sorry, ma'am. So that's the outline of the diaphragm, and usually, if you can see here, on the right-hand side, this area below the diaphragm is white in color, so it is radio opaque. However, in case of a patient with perforated peptic ulcer or a patient who has signs of pneumoperitoneum, there would be radiolucency. You could see the outline of the diaphragm properly, and there would be a radiolucent area here. I unfortunately missed out on putting the slide or a picture of pneumoperitoneum, but I think it would be great if you could you can all go back and Google pneumoperitoneum. I'm sorry about that, but there would be a radiolucency present just below the diaphragm. So that would also, this chest X-ray would not only help me rule out pneumonia, but also one of my major differential diagnosis, which is perforated peptic ulcer. So moving forward, I would then also order for a X-ray of the abdomen for me to rule out firstly, to rule out subacute intestinal obstruction, and also because there are certain signs that you can see in acute pancreatitic patients. And I have mentioned only one sign here, which is called the sentinel loop sign, in which, because of the inflammation of the pancreas, I would, okay, because of the inflammation of the, so this is what is referred to as a sentinel loop sign. So usually on an erect X-ray of the abdomen, you wouldn't see the outline of the bowel in a certain way, such as this. So this occurs because inflammation of the pancreas causes ileus, or ma'am, I cannot explain ileus in a better way.
So because in the definition of acute pancreatitis, it says that it is the acute inflammatory condition of the pancreas that affects the regional organs, as well, not only the regional organs as well as the remote organ. Okay, so regional organ would be transverse colon, the loop of jejunum. Okay, so there will be colon cutoff sign, sentinel loop of jejunum. That's all because of the inflammation you will see. And the remote organ is, like you very rightly mentioned, pleural effusion. It will affect the kidney as well. It will affect the cardiovascular system as well. Okay, so those are the signs. And in some cases, you will see a renal halo sign. You will see a radiolucent shadow around, along the outline of the kidney. Okay, so those are the various signs you will see in acute pancreatitis. And Kanchana, I would like you to use the word of partial small bowel obstruction or partial large bowel obstruction instead of subacute intestinal obstruction, because subacute intestinal obstruction includes very many things. Even ureteric colic can cause that condition. Okay, so it's better not to use that word, but it depends upon the institution as well. In some institute, they are still using that word, but the better word would be partial small bowel, large bowel, or paralytic ileus. Okay, right?
Yes,
Okay,
ma'am.
go on.
Thank you, ma'am. This abdomen, X-ray abdomen erect would also help me rule out, as ma'am rightly mentioned, a partial small bowel obstruction. And if it had been a case of partial small bowel obstruction, we would have seen multiple air fluid levels on the X-ray, but that would have helped us rule out acute intestinal obstruction. So following this, as ma'am rightly mentioned, we also sent for an ultrasonography of the abdomen and the pelvis. And so in this patient's ultrasonography, biliary sludge and gallstones were present in the gallbladder. And I haven't mentioned here, but there was no inflammation of the gallbladder. There was no vascular, I don't remember the term properly, but there were no signs of inflammation of the gallbladder. So this is the ultrasonography report. And here, as you can see, the abdominal wall is visible. The liver and the pericholecystic fat is also visible. What we're more concerned with usually is seeing the acoustic shadow. So if there is, as you can see here, at the at the level of gallstones, if you see under that, then you see a break in the whitish surrounding area. So that's called an acoustic shadow, and that is the sign of presence of gallstones in the on the USG, and presence of biliary sludge and gallstones. Also, now this also helps us reach a diagnosis of acute pancreatitis, because it gives us a clue as to what might have caused the acute pancreatitis. So the presence of biliary sludge and gallstones may have led to, now that gives us a clue that lets us go back to the symptoms the patient had and why she had those symptoms. So moving forward, okay, so moving forward, so as ma'am rightly mentioned earlier, this pancreatitis can be divided into mild, moderate, or severe pancreatitis, and it is dependent on the following, the presence of the following factors that I'm going to be talking about now. So I think in order to understand mild and moderate pancreatitis, we can start with severe pancreatitis. So if a patient has evidence of organ failure, so which means that organs other than the pancreas itself, we will be talking about what organs, but for now, if there's a failure, there's some form of organ failure for more than 48 hours. So if there's persistent organ failure, then that is a sign of severe pancreatitis. So this persistent organ failure means that this organ failure needs to last for more than 48 hours. Now, initially, when we send all the lab investigations, that will give us a clue as to whether there is organ failure or not. For example, if you remember, we mentioned about the renal function test. So if there's a patient with acute pancreatitis who comes with deranged renal function test, then we can imagine that the patient might have some other organ failure. But at this point of time, you cannot say when the patient has presented whether that is persistent or not. So for now, we're going to say that the patient had severe organ failure. Now, if the patient did not have organ failure, then that patient will have mild acute pancreatitis. So presence of organ failure means the patient had severe acute pancreatitis, and if the patient had no organ failure and no local complications. So local complications means peripancreatic fluid collections or pancreatic necrosis or peripancreatic necrosis. Now, local complications of pancreatitis are the ones that have been mentioned here. Generally, what happens is, because it is an inflammatory process, there is a collection of peripancreatic fluid, which leads to a collection in the abdomen. And this collection in a patient who has had pancreatitis for a while will be visualized either as a mass per abdomen, which we would have seen in the patient while we were palpating the patient, clinically examining the patient, or we would have seen it on ultrasonography if there was a collection. So this means that no local complications and no organ failure means the patient has mild acute pancreatitis. Similarly, the patient also does not have any systemic complications. And this acute pancreatitis, now at this point of time when we've just seen the patient from the emergency, we cannot see if the patient will recover in 1 week, but mild acute pancreatitis patients typically have their symptoms resolving in the first week. Now, yes, ma'am.
So, Kanchana, so what you do, once you confirm the diagnosis of acute pancreatitis with the 3 criteria according to revised Atlanta classification, then you need to see whether the patient has got organ failure or not. Okay, so that thing is decided by modified Marshall scoring system. I don't know whether you have included that or not in your slides. Modified Marshall scoring system includes 3 things: systolic blood pressure, right? So you do exactly. She has very nicely shown what are the things that we see. And that is, one is the systolic blood pressure. The other one is serum creatinine. And the third thing is the respiratory, which includes PaO to FiO2 ratio. That is the very reason why you need to do EBG, right? So you see all these parameters at the time of admission, the emergency. And if the score is 2 or more, then you say that the patient has got organ failure. So that patient is categorized as severe acute pancreatitis in the emergency. and then you triage that patient and you admit that patient in high dependency unit, either in the surgical ICU or in the general ICU. Okay, and those patients who do not have organ failure are categorized as mild acute pancreatitis. Okay, so at 48 hours, like you admit the patient, and at 48 hours or after 48 hours, you again repeat, you again see the patient's systolic blood pressure, you measure his serum creatinine level, you again do ABG and see PaO to FiO2 ratio, and if the modified Marshall scoring system, modified Marshall score is still 2 or more, then you label that patient as a persistent organ failure. So that patient will be severe acute pancreatitis. But at 48 hours, if the organ failure does not persist or improves, then that patient will go into the category of moderately severe acute pancreatitis. Okay, so here comes the value of resuscitation, how well you resuscitate. If the patient has received adequate resuscitation in terms of fluid, then that patient will not go on to will not have persistent organ failure. He will improve. Okay, at this point of the time, you classify mild, moderate, severe according to modified Marshall scoring system only, because in order to define local complication, you will need some time. Okay, and systemic complication means aggravation of the comorbid condition, like it's written in the moderate severe acute pancreatitis. Aggravation of comorbid condition means if the patient, the hypertension deteriorates, COPD deteriorates, patient's blood sugar become diabetic patient's blood sugar becomes uncontrolled. Okay, those are systemic complications, right? So in that way, you categorize the patient into mild, moderate, severe in the early period. Okay.
Yes, ma'am. So thank you for explaining it in a very short and concise and very comprehensible manner, ma'am. Because I think we tend to, as students, we tend to get lost until and unless we actually do it ourselves. So if we actually go and see the patient every day, and then we see why the diagnosis was mild pancreatitis until yesterday, and today suddenly the patient has become moderate, or it was severe yesterday and now it's moderately severe. So that's how I learned as well. So I think moving forward from, I would like to move forward from this. So this severity of acute pancreatitis has been divided into mild, moderate, and severe. But coming to that, ma'am has already mentioned about modified Marshall scoring system. But in our books, we will also see these two criteria called the Ranson's criteria and the Glasgow criteria for acute pancreatitis, which were used earlier for assessing the severity of acute pancreatitis. And but now at this point of time, even though the modified Marshall score may not necessarily be in our books, that is the one that we've been using in our institution as well. And I think that is the most recent one, ma'am. Please do correct me if I'm wrong, but I think that is the scoring system that we use to assess the severity. So you can, for my juniors who are going to appear for the exam, I think these are good to know things, because sometimes ma'am may ask you, what are the other scoring systems that you know? So then these will come in handy. But other than that, as per now, we use the modified Marshall scoring system, and I think ma'am has explained it beautifully. I would also like to mention here that again, that ABG is done. So arterial blood gas analysis is used for looking for the PaO to FiO2, basically a measure of respiratory function, and we need to do ABG in the ER so that you can assess the severity. And we use the modified Marshall score for assessing the severity in acute pancreatitis. And when we were in the emergency, we also calculated the modified Marshall scoring system for this patient. So the patient's PaO to FiO2 was 222.5, which was a score of 2. So basically, there's a lab value that comes on the ABG report, and then you just see where it lies in the severity score. So there's a score from 0, 1, 2, 3, and 4. And then for all the 3 criteria, you just add the score up. And then if the total score is more than 2, then you classify it as severe. So in this patient, the patient's FPO to FiO2 was 222, which gives the patient a score of 2. Similarly, the creatinine was 144 milligram per deciliter, so that was a score of 1. And the patient's blood pressure was 110 by 70 when we measured it again. So that gives us a score of 0. So this means that the patient's modified Marshall score is 3. So which means that the patient initially was classified as a severe case of acute pancreatitis. Along with this, we also do something called the Bisap score, and this is the full form of Bisap is bedside index for severity of acute pancreatitis score, and this further includes some other criteria. So the first one is blood urea nitrogen. So as you can see here, in case of acute pancreatitis, assessing the severity is very important because management is according to the severity of the disease. So if a patient has severe acute pancreatitis, the patient will have derangements in some other values as well, despite not just the values that are related to pancreatic function, but also blood urea nitrogen, and then the impaired mental status, which is also one of the factors that determine the severity of the patient. So this is where our clinical examination skill comes in, because if the patient is drowsy, if the patient is not conscious, then that automatically makes us think that this patient might have severe disease. Now there's something else here, which ma'am mentioned earlier. So this is SIRS. This is Systemic Inflammatory Response Syndrome. So in this, I will be coming to the slide which shows what SIRS is, but we just need to remember that the vital signs are called vital signs for a reason. So they help us rule out conditions that may lead to, that may help us detect whether the disease is very severe or not very severe. So I will be coming to SIRS in a moment. So age more than 60 years is also one of the factors that determine the severity of the patient. And pleural effusion on chest radiography or CT scan is also one of the indicators of severity of disease in the patient. So as we can see here, there are two factors in this scoring system that are present in the patient. So first is age more than 60 years, and the second one is pleural effusion. So the total score of the patient is 2. However, 2 is a relatively low score and it indicates less chances of mortality. So Bisap score gives us idea about how the patient's prognosis is going to be following the disease. So if at presentation only the patient has probably 5 of a Bisap score, then that will tell us that the patient might have more chances of having a worse prognosis than a patient who had 2, and 2 would indicate a low mortality. Now there's a chart which tells you what is the percentage of mortality in a patient with a certain Bisap score, which I did not include in this presentation, but if you're interested, you can always go ahead and read about it. So I believe I had added a slide on SIRS, but I seem to have lost it somewhere. So I was just so SIRS generally includes most of the things that we already see in our vital signs. So the first is temperature. So one of the first vital signs is temperature. So when we measure the temperature of the patient, if the patient is febrile, or if the patient has hypothermia, so that is a temperature either less than 36 degrees Celsius or more than 38 degrees Celsius, that comes as a that is one of the signs of SIRS. Similarly, the next one is the patient's respiratory rate. The patient's respiratory rate more than, I'm looking for this slide, but I can't seem to find it. I think it's here. Okay, I can't seem to find it, ma'am.
So I think the students will go and read themselves. As you very rightly pointed out, it includes heart rate, right?
Yes, ma'am.
WBC count, temperature, and respiratory rate, right? So if out of the 4 things, if two is present, then it is considered as the patient. It is said that the patient has got SIRS. Okay.
So moving forward, moving forward, ma'am. After all these investigations, my final diagnosis is acute severe biliary pancreatitis.
Mm-hmm.
And now I would like to proceed towards the management of this patient. So,
Kanchana,
yes, ma'am.
so at this point of the time, I would like to tell you all that whenever you come across a patient with acute pancreatitis, you have 4 questions to answer. So till now, we have answered 2 questions. The one is whether my patient has got acute pancreatitis or not, okay, which we have done with all the investigation and clinical features. Okay, and the second thing is that after you confirm the patient has acute pancreatitis or not, then you need to see whether what is the severity of the disease. Okay, so that is also has been done with a modified Marshall scoring system with Bisap. Sometimes, as you rightly said, you can do Ranson's criteria. There are battery of investigations, right, which you can categorize as scoring system, as you mentioned, Glasgow, Ranson, Bisap, and the second group is laboratory markers like C-reactive protein, okay, urinary trypsinogen level, okay. Out of those, even the level of interleukin 6 is measured, but the most important is CRP level, C-reactive protein level, and they have to use the cutoff of 150 nanograms per ml or deciliter as the cutoff to categorize to keep the patient into the group of severe acute pancreatitis. If the level is more than 150, then it's severe acute pancreatitis. Okay. The third group of severity marker is imaging, like CT. I think you will come to that. CT severity index, Balthazar scoring are also there. So these are the uh, three group of parameters by which you can decide whether the patient has got severe acute pancreatitis or not. Okay, modified Marshall scoring system is to see whether the patient has got organ failure or not. Although organ failure directly extrapolates into patient having severe acute pancreatitis, but it is not a severity scoring system. It is a organ failure scoring system. Okay,
Yes, ma'am.
so 2 questions we have answered. The third question is now, how do I treat this patient, manage this patient? Okay, let's continue.
Ma'am, in terms of management, I have included the management that we do initially in the ER, and management of acute pancreatitis. Initially, it accounts only for resuscitation. So we need to provide adequate resuscitation to the patient in order to stabilize the patient, and then we go towards definitive management depending on the cause of acute pancreatitis. So here, just to give an idea on how we approach this patient in the ER and what was in the cardex of the patient, I would like to read out this management. So because the patient had symptoms of vomiting, the patient had vomiting and the patient could not eat anything properly. So a nasogastric tube, which we also called as a Ryle's tube, was inserted, and the patient was kept nil per oral. So nil per oral means you don't give the patient anything to eat by their mouth. Similarly, we also gave the patient oxygen via face mask, because as we might be remembering that the patient had SpO2 93% and 2 liters of oxygen only, so the patient's saturation was dropped. So similarly, management of acute pancreatitis means treating all the things that are going wrong symptomatically. So because the patient is expected to have hypovolemia, we maintain the fluid balance of the patient. So the patient was kept on injection Ringer's lactate at 100 milliliters per hour. So for my juniors who are appearing for this exam, please know how to calculate fluids in patient, because that's a very interesting question that pops up on the exam. And similarly, we also keep appropriate antibiotics, such as broad spectrum antibiotics, in order to treat the patient of acute pancreatitis, which is not usually for the treatment of pancreatitis, but we just want to minimize the chance of infection in this patient. So appropriate antibiotics may include ceftriaxone or metronidazole. Generally for GI infections, we tend to use metronidazole and ceftriaxone. Similarly, because the patient is having pain, we also need to put appropriate analgesics. So we use injection paracetamol 1 gram QID. This paracetamol here is not to treat the fever of the patient, but instead this is to make sure the patient does not have pain. So here paracetamol is used not as an antipyretic, but as an analgesic. So similarly, we also put injection pantoprazole 40 mg once daily to the patient. And because yes, ma'am.
So, Kanchana, you can sum up all these management in one phrase, which is frequently used is aggressive medical management. Okay, please understand the treatment of acute pancreatitis in the early phase is aggressive medical management in the form of IV fluids, as you mentioned, and the fluid resuscitation should be liberal, because if you are very conservative in resuscitating the patient, if the patient is not resuscitated well, then the chance of patient going into severe pancreatitis increases, because pancreas is a very sensitive organ to fluid, and because of hypoperfusion, because of all the inflammation that is going on, if the fluid resuscitation is not done well, then there is increased risk of that pancreas going into necrosis. Okay, so fluid resuscitation is very important. The one and for very important thing is fluid resuscitation, and it is said that fluid resuscitation in acute pancreatitis should be as in a case of burn, right? When we do fluid resuscitation in burn, we calculate fluid from the starting from the time of burn, right? So similarly, there has been so much stress has been given in fluid resuscitation, and it should be a liberal fluid resuscitation, which is, and whether your fluid resuscitation is adequate or not is measured by decrease in heart rate, decrease in tachycardia, adequate urine output, okay, all those things. And also in ABG, you monitor the lactate, make sure the lactate is normal, indicating that your resuscitation is adequate. And the second thing is that after fluid resuscitation is pain management. So there should be adequate pain management, and pain management is done according to the WHO ladder. Although it is done according to the WHO ladder, since the patient has got very severe pain, we tend to give a strong analgesics initially. And there was a lot of misconception that morphine should not be given because morphine causes spasm of the sphincter of Oddi, further aggravates acute pancreatitis, but that is not true. You can even give morphine or other narcotics like opioids like pethidine, tramadol, and all that. Okay, so I don't think paracetamol may be adequate for a patient who has mild acute pancreatitis, but in patients who have severe acute pancreatitis, you have to give some strong analgesics. And the third thing is that obviously the proton pump inhibitor, right? And actually, there is no role of antibiotics initially in acute pancreatitis. What we need to understand is in the early phase, that is in the first week, whatever is happening to the patient, the leukocytosis, the fever, the tachycardia, is not because of infection. It is because of SIRS. So there is no role of antibiotics until and unless the patient has got infection, maybe urinary tract infection, maybe pneumonia, maybe if the patient has got acute cholangitis, then only there is role of
Hello.
There seems to be a connection problem.
Yeah, I think we lost ma'am.
Okay, we could wait a couple of minutes.
Yeah.
दिदी हजुरले कन्टिन्यू नै गर्दिनु अनि म्याम
Actually, this is the last slide.
Okay.
I think the second last slide. So just a little bit about monitoring. So a patient who has acute pancreatitis needs adequate monitoring, especially in terms of you will do monitoring throughout, but you need to check for renal function tests. And if a patient has mild acute pancreatitis also, they may progress to severe acute pancreatitis. So ample monitoring is required, and definitive management, especially in terms of gallstone pancreatitis, as we have seen in this patient. Usually ERCP can be done within 72 hours only for severe gallstone pancreatitis, or if there are signs of cholangitis. Now, definitive management obviously differs depending on the cause of acute pancreatitis, but usually, if the patient had pancreatitis because of gallstone disease, we first resuscitate the patient, stabilize the patient, and then we can opt for surgery further. Right, so I think this is about it. Now I'll be talking a little bit about the local complications of acute pancreatitis, and then I think if ma'am is back by then she can add on to that. So basically, if there's pancreatitis has local complications in terms of if the complication arises in less than 4 weeks, and if it is only an edematous pancreatitis. For example, if it is not, if there is only just mild inflammation, and then there's edema, and then there's, how inflammation works. There's migration of neutrophils, and then there's this whole edema, accumulation of inflammatory mediators, chemokines, all those things taking place. Then if there's a complication in less than 4 weeks, it is known as acute peripancreatic fluid collection. And this fluid collection organizes, and after 4 weeks, it is known as what we call the pseudocyst. So it is called the pseudocyst of pancreas, and not pseudopancreatic cyst. Okay, so you cannot use the term pseudopancreatic cyst, and this is one of the mistakes that we make during our exams. So please focus on that. And then there's another form of acute pancreatitis. So this is acute interstitial necrotizing pancreatitis, right? So this is like a classification of acute pancreatitis based on the pathophysiology. So if there is a necrotizing pancreatitis, usually if there is a collection less than 4 weeks, then it's called an acute necrotic collection. And if it is more than 4 weeks, it is called wall of necrosis. So basically, if a patient who had epigastric pain for example, 4 weeks back or 5 weeks back, epigastric pain, a single episode, and then they present with a mass abdomen, then we can suspect a pseudocyst of the pancreas. But to go more into the local complications would be I think that would take a lot of time. So beside the local complications, there are also certain systemic complications. I know. So systemic complications include, as we've mentioned earlier, deranged renal function tests, and they can have shock, arrhythmias. There's a wide range of systemic complications that can happen in a patient with acute pancreatitis, but these are the local complications that we need to know, and this is on the basis of revised Atlanta classification. So I don't know if it's in the newer edition of Bailey's, but I took this off the guideline itself, so maybe you guys can keep note of this. And that brings us to the end of today's discussion. Thank you. If there are any questions.
So Kanchana, back. I'm sorry.
I'm sorry, ma'am. I didn't know you were back.
Sorry. No problem. So can you go back?
Yes, ma'am.
So regarding NG tube, not in all patients we put nasogastric tube, even if the patient is vomiting. Right. In the past, it was a dictum that all the patients with acute pancreatitis, NG tube needs to be placed, stomach needs to be decompressed and managed. But these days, we do not put nasogastric tube unless and until patient has got some ileus and recurrent vomiting, right? And then you've talked about, I saw you mentioning about ERCP. Okay, yes, so before going into before talking about ERCP, I would again like to stress that the initial management can be summarized the phrase known as aggressive medical management. Okay, please note that aggressive medical management, where the first thing is fluid, second thing is analgesic, and there has been so many studies in the past investigating various drugs in the management of acute pancreatitis to interrupt the inflammation, but but none of the drug has been found to be useful. There was a time when they investigated protein, gabaxate, lexipafant, and all these were found to be effective in the management of acute pancreatitis. And there is another drug known as ulinastatin. You can go and read about it, although in some centers they are using this drug ulinastatin in the management of acute pancreatitis. Okay, so we've answered the third question, how do we manage the case, right? And the fourth question in the management of acute pancreatitis is what is the cause of acute pancreatitis? So what I wanted to stress, why this question is in the end is because in the early phase, we are not worried about knowing the cause of acute pancreatitis. We are worried about treating the symptom of acute pancreatitis. As you mentioned, that we treat the symptom, whatever symptom patient has, we treat initially. Okay, so during the initial part, then you investigate whether the patient has got gallstone or not, whether the patient has got hypercalcemia or not, whether the patient has hypertriglyceridemia or not, whether the acute pancreatitis was because of any drug or not. Okay, so cause of it is important to identify the cause of pancreatitis before you discharge the patient, so that the cause is treated and the patient does not come back to you with recurrent pancreatitis. Okay, so if it is the gallstone disease, it is said that textbook says that you do a laparoscopic cholecystectomy before the patient is discharged. Okay, that is in mild acute pancreatitis. In moderate and severe acute pancreatitis, you treat the complication and then you do laparoscopic cholecystectomy. And if acute pancreatitis is because of alcohol, then there is a term known as alcohol counseling. Okay, you tell the patient that your pancreatitis was because of alcohol, and this pancreatitis is a severe disease. You may even die, so better you not drink alcohol. What I say to my patient is, सुङ्नु पनि हुँदैन के, खाने त कुरा छोड्दियौ, सुङ्नु पनि हुँदैन. Okay, so it has been, they have done in US, they have done studies, and they have found that alcohol counseling significantly decreases the incidence of recurrent pancreatitis in patients where the cause is alcohol. Okay, and similarly, it's important to identify the cause before you discharge the patient, so that the patient does not come back to you again. So all these are the initial management of the acute pancreatitis. Okay, so if you all are interested, I can just show a few things, how the acute pancreatitis looks like in CT. Okay, so only things I can show you. Okay,
ma'am, I'll stop sharing my screen now then.
Right, it's already 5:30. What do the organizers say? And I don't see any questions. If you all have questions, you all can ask.
Okay, I'm sure there might be a lot of questions. Yes.
So do you want to take questions, or do you want to see a few things that I have?
Yes, ma'am. At first, we'd like to see, and we'll entertain few questions.
So are you seeing my screen or not?
Yes, ma'am.
You see my screen?
Yes, ma'am.
So I just want you all to know that how severe acute pancreatitis can be. Okay, in 1925, Lord Moynihan had described acute pancreatitis as the most terrible of all the calamities that occur in connection with abdominal viscera. The suddenness of its onset, the illimitable agony which accompanies it, the mortality attendant upon it render it the most formidable of catastrophes. So by saying this, by this statement by Lord Moynihan suggests that acute pancreatitis can be a very severe disease. Okay, so this Dr. Kanchana has already shown. is straight from the horse's mouth. I've taken this from the article published by the group which revised the Atlanta classification in 2012. And so according to this revised Atlanta classification, we have 3 categories: mild acute pancreatitis, moderately severe acute pancreatitis, and severe acute pancreatitis, which we have already discussed. And there is another classification as well. And I think in some institute, for example, in Kathmandu Medical College, and even in Nepal Medical College, in some institution, some of the consultants may be using this classification. So I would like you to know this classification as well, which is known as determinant based classification. And here they have added critical acute pancreatitis. So critical acute pancreatitis comes when they're in the second phase of the acute pancreatitis, where the patient has complication of the infection of the local complication. Okay, so mild acute pancreatitis is there is no peripancreatic necrosis, there is no organ failure. Moderate means there is necrosis and or transient organ failure. Severe means infected necrosis or persistent organ failure, and critical means infected and persistent organ failure. Okay. So I talked to you that even CT helps us in assessing the severity of acute pancreatitis. So this is CT Severity Index, which we use at our institute as well. And it consists of the Balthazar grading, where the pancreatitis is graded into A, B, C, D, E, and 0 to 4 points are given depending upon the severity. And the necrosis is classified into less than 30%, where the patient gets 2 points, and 30 to 50% patient will get 4 points, and more than 50% the patient will get 6 points. Okay, and then these two are added, and it is said that if the CT severity index is between 7 to 10, then the morbidity is very high in the range of 92%, and the mortality in the range of 17%. And there is another modified CT severity index as well, where extra pancreatic complication, as Dr. Kanchana very nicely explained about the pleural effusion. And it's not just the pleural effusion, there can be vascular complication as well. There may be portal vein thrombosis, there may be splenic vein thrombosis, and there may be gastrointestinal tract involvement, that the colon may get necrosed, patient may have ascites, patient may have pleural effusion. So all these extra pancreatic complications are also included. And here necrosis is classified into less than 30% and more than 30%. And then again, the points are added. And here also depending upon what the point patient receives the point, CT severity index is, the morbidity and mortality depends upon it. Okay, so and then whenever we discuss acute pancreatitis, it is important to know when to do CT scan. Okay, there are 4 indications of doing CT scan. Number 1 is at the time of admission, when the diagnosis is there is diagnostic dilemma, and number 2 to grade the local complication, as Dr. Kanchana described. So to grade the local complication, we do CT scan at the end of the week. At the end of the week means not immediately after admission, but at the end of the week, after end of the first week of treatment, because at that time all the local complication will get evolved. Okay, and the third indication is, despite your aggressive medical management, if the patient starts deteriorating, then it indicates that something wrong is going on, so you want to do a CT scan. And fourth indication is, sometimes you may have to do CT scan to identify the cause, like patient having annular pancreas, patient having pancreas divisum, sometimes even pancreatic cancer, ampullary carcinoma, a cyst in the pancreas can cause acute pancreatitis, which is for which we need to do CT scan. Okay, so Dr. Kanchana already described the local complication, and this is according to the revised Atlanta classification. Okay, and interstitial edematous pancreatitis, or we have necrotizing pancreatitis. Okay, and in less than 4 weeks, the fluid collection are described as acute peripancreatic fluid collection, which may be sterile or infected, or acute necrotic collection, which may be within the parenchyma. It may be peripancreatic or combined pancreatic and peripancreatic, and that can be sterile or infected. Okay, and after 4 weeks, she has very nicely mentioned, it becomes pseudocyst. The acute peripancreatic fluid collection becomes pseudocyst, and if it can get infected as well, and acute necrotizing pancreatitis go on to develop walled off necrosis, which can be sterile or infected. Okay, so this was what used to be described in the past when revised Atlanta was not there. Okay, so and then the same thing you can see this in this picture. You can see acute peripancreatic fluid collection, right? And that acute peripancreatic fluid collection after 4 weeks go on to become a pseudocyst, which is an encapsulated, well-defined extrapancreatic fluid collection. Okay, and then acute necrosis. Necrosis means the pancreas that does not enhance. The enhancing pancreas will look like this, bright one, and here the pancreas is not enhancing. It is not bright after contrast. So these are the necrotic area, and these necrotic acute necrotic collection will after 4 weeks will go on to become a walled off necrosis, and you can see these black spots that is there inside the necrosis, which indicates it is infected necrosis. Okay, it's not always necessary to get the tissue for culture. Even with this what you are seeing air inside the necrotic collection, it will indicate the patient has got infected walled off necrosis. Okay, the same thing here. You can see some peripancreatic fluid collection, and then this part is necrotic pancreas. This part of the pancreas is enhancing. This is not enhancing. The non-enhancing part of the pancreas is known as necrotic collection, and then that necrotic collection has become walled off. Okay, and you can see some solid component as well. If you see solid component, it will become a walled off necrosis. If you just see fluid only, that is usually a pseudocyst. And then, as shown before, there are air trapped within, which indicates infection. Okay, and then this is another statement in the management of acute pancreatitis, which says that a 10-minute surgical discussion of acute pancreatitis probably includes 9 minutes of silence. Okay, so we've discussed almost 1 hour. So where is the role of surgeon? There's no role of surgeon. So in the initial period of management of acute pancreatitis, everything is medical management. That's why I again stress it is aggressive medical management. Okay. So these are the various interventions that is done for acute pancreatitis, for necrosis, necrotizing acute pancreatitis. I think this will take another big lecture to discuss. So I think we will take questions. Okay, and then this is what a necrotic pancreas look like. Okay, it looks like a naliko pani. Okay, with all these things, right? So let the organizers take questions, right? We can discuss it. In order to discuss all these things, it will need another one big lecture, right? So this is the last slide, which summarizes everything about management of acute pancreatitis, what we do in the first week, what we do in second and third week, what happens in after that. Okay, so acute pancreatitis is a very prolonged disease if a patient has severe acute pancreatitis, right? If a patient has got mild acute pancreatitis, it's just like treating any patient with acid peptic disease. Okay.
Thank you, ma'am. This was really an informative session. So if anyone is interested or if anyone has queries, so please you can drop your queries on the chat box. And I would like to coordinate our co-host with the mentor for the queries.
Ma'am, there is one question from Anviti Parazuli. She asks whether you could explain about the use of total parenteral nutrition versus the feeding via nasogastric tube in the patient with acute pancreatitis. And also she is asking for further explanation on the X-ray signs of acute pancreatitis.
So very nice question, very good questions. Who is the student asking?
She is Anviti Parajuli.
Okay, Anuditi Parajali, very nice question. We did not talk about nutrition, and you very rightly mentioned nutrition is very important in acute pancreatitis, and you need to start nutrition as early as possible. Early enteral nutrition. Okay, it's enteral. If the patient can eat, then you start orally. If not, then it is recommended to put in nasogastric tube or nasojejunal tube and start early enteral nutrition, because when you give enteral nutrition, the gut mucosal barrier is maintained. There is no translocation of bacteria, and the risk of infection to the pancreas significantly decreases. And the most important and very dreadful complication in acute pancreatitis is infection of the pancreas, whether it is pancreatic fluid collection or acute necrotizing pancreatitis. Infection should not be there. So in order to prevent infection, in order to prevent translocation of bacteria, you need to maintain the gut mucosal barrier, which is done by enteral nutrition, either oral or nasogastric or nasojejunal, which you need to start as early as possible. But sometimes in patients with severe acute pancreatitis, where there is large necrotic collection or peripancreatic fluid collection, which may compress the stomach, patient may not be able to eat, patient may not tolerate nasogastric tube, nasogastric feeding, you are unable to put a nasojejunal tube, then or if the patient has got ileus where enteral nutrition is not feasible, then you can start with total parenteral nutrition. But as far as possible, we have to aim for enteral nutrition. Okay. Regarding the second question, acute pancreatitis is classified into interstitial edematous pancreatitis and acute necrotizing pancreatitis. Okay, and the complication is acute peripancreatic fluid collection. As you see here, acute peripancreatic fluid collection. Okay, which after 4 weeks becomes the pseudocyst. Pseudocyst is an encapsulated, well-defined collection of the pancreatic fluid. Okay, it is a pseudocyst because it does not have a true epithelial lining. The wall is formed by granulation tissue. Okay, that is a pseudocyst. And the acute necrotic collection means, as I showed you in this picture, like this whole is the pancreas. Okay, so after contrast, the normal pancreas will enhance like this. So any necrotic area will not enhance. So this is not enhancing. This is hypodense. This is hyperdense. Okay, so hypodense area, the part of the pancreas which does not enhance in the contrast is considered as necrotic area. Okay, so this is acute necrotizing pancreatitis, which after 4 weeks becomes a walled off necrosis. All the necrosis becomes liquefied and becomes a walled off necrosis. And when this walled off necrosis becomes infected, then you can see gas within the collection, walled off necrosis. I hope that's what she wanted to know. Okay. Did I answer your questions?
Thank you, ma'am. I hope the query is resolved. If there are any further questions, then you can kindly mention that in the chat box.
Ma'am, I want to ask one question. In acute pancreatitis, the head of the pancreas is swollen and edematous. In that condition, can we feed by the nasogastric tube, ma'am?
Yes, the edematous pancreas will not cause gastric outlet obstruction. It is the collection, okay? It is the collection, and sometimes because of the severe inflammation, there will be, just like there is ileus of small intestine, there will be delayed gastric emptying. So, or even if there is no obstruction, the patient will not be able to tolerate the feed. The patient will have vomiting because of delayed gastric emptying, which is the result of local inflammation around the stomach, that is in the pancreas. So even if the pancreas is edematous, we still can go for nasogastric feeding. If nasogastric feeding is not possible, we can put a nasojejunal tube and feed. Nasojejunal tube are relatively longer tube than nasogastric tube, which is kept with, which is inserted either with the help of a fluoroscope or with the help of endoscope. Okay.
Okay, ma'am. Thank you, ma'am. Ma'am, there is another question from Amit Thakur. He has asked, in biliary pancreatitis, we have to first manage the biliary lithiasis or acute pancreatitis?
That's what I've been telling you. So initial management is supportive treatment. Dr. Kanchana also specifically mentioned you treat the symptoms, the initial early management. Now we are just discussing the early management of acute pancreatitis. We need to have another class on management of late management of acute pancreatitis, that is management of all these complications, pseudocysts, management of walled-off necrosis. Okay, so initially it's just medical management. So, and if the cause of acute pancreatitis is gallstone, and if the acute pancreatitis is mild acute pancreatitis, then ideally all the guidelines says that you do laparoscopic cholecystectomy before you discharge the patient. So you treat the patient for 4 days with medical management, and then when you think that patient has improved, if you have a operating slot, you go for laparoscopic cholecystectomy and then only discharge the patient. That is not the case in our setup. We cannot go for a laparoscopic cholecystectomy like that. So we call our patient after 6 weeks for laparoscopic cholecystectomy. Okay, so initially you manage symptomatically, and then if it is mild acute biliary pancreatitis, then you try to do laparoscopic cholecystectomy in same hospital setting. Okay, so for that it depends upon the institutional policy. At our institute at one university teaching hospital, we are not doing that. But in private setup, maybe in some of the medical colleges, as far as I know, in Kathmandu Medical College, they go for cholecystectomy once the medical management is finished. Okay.
Thank you, ma'am. Ma'am, there is another question, and I have also doubt, and one of my friend has also asked me, in if we suspect the patient is suffering from acute pancreatitis, then we should not give him the prophylactic antibiotic therapy. I have read in some book, ma'am, and I am in
Yes,
doubt.
yes, that's what I mentioned while Kanchana was presenting. There is no role of prophylactic antibiotic in the management of acute pancreatitis. Okay, because what we need to understand is the early phase, whatever is happening to the patient, that is tachycardia, fever, leukocytosis, it's all because of systemic inflammatory response syndrome. See, so in the early phase, we do not give any antibiotics. We give antibiotic in the early phase only if there are other signs of signs of infection, documented infection. For example, pneumonia, urinary tract infection. If the patient has got concomitant acute cholecystitis, if the patient has got cholangitis, then only we give antibiotics. Otherwise, there is no role of prophylactic antibiotic in the early management of acute pancreatitis. Okay.
So I
Any other
guess,
question?
yes. So I guess most of the queries are covered.
Right.
So are there any queries? So I guess there are no queries.
There is one question, and the question is, can we know a bit about third space loss? How does that happen, and how can it be resolved?
So So I mentioned that okay, the pathophysiology of acute pancreatitis is similar to that of burn. Okay, when there is severe inflammation, the capillary becomes leaky, so there is lots of fluid sequestration, and the patient becomes hypovolemic. The perfusion to the pancreas decreases. Okay, so blood space loss happens because of the severe inflammation. For that, we need to go in pathophysiology of acute pancreatitis. And I think Dr. Kanchana rightly mentioned about all those cytokines and all those inflammatory mediators because of which capillary leaks occur. Okay, and that is treated by aggressive fluid management. Okay, so so it is important to treat all these patients initially with adequate fluid resuscitation, liberal fluid resuscitation, so that all the organs are perfused well, and third space loss is covered with that fluid resuscitation. Right? You cannot stop that third space loss because of the once the inflammation cascade starts, it goes on. There is no way you can interrupt that inflammatory cascade. That's the bad thing about acute pancreatitis. But you can correct it with adequate fluid resuscitation. I hope I answered your question.
So I hope all of the queries are answered.
So I just see another
one question is there.
Okay, yes.
question over there about ERCP. Yes, ERCP, I hope everybody knows what is ERCP is. ERCP is done to remove the common bile duct stone endoscopically. It's used to the stent, right? So it is also done to drain the biliary system. So ERCP is one of the cause for acute pancreatitis, which is termed as post-ERCP pancreatitis. So Anil Bishta wants to know what are the factors to be considered during ERCP after initial. The main cause. So what factors are to be considered during ERCP? I did not get the question.